Welcome to this video entitled, Management of Diabetes in Stroke. As a way of introduction, diabetes mellitus is a global health problem. About 350 million people worldwide are affected, and this number is expected to increase by a staggering 50% in the next decade because of increases in the prevalence of obesity and inactivity. Type 1 diabetes mellitus, which accounts for about 10% of all cases, is an autoimmune disease where there is immune destruction of the insulin-producing pancreatic beta cells. Type 2 diabetes mellitus, representing 90% of people with diabetes mellitus, is caused by progressive pancreatic beta cell failure in the context of increased insulin resistance. Next we will discuss diabetes as a risk factor for stroke. Diabetes is a well-recognized risk factor for stroke, and there may be a sexual dimorphism in the stroke risk imposed by diabetes. A recent systematic review and meta-analysis of 64 cohorts, including 775,385 individuals and 12,539 strokes, is instructive in this regard. The duration of follow-up was between 5 and 32 years and included data on both fatal and non-fatal strokes. Compared with individuals without diabetes, those with diabetes, not surprisingly, had higher systolic blood pressure, total cholesterol levels, body mass index, and waist circumference and lower high-density lipoprotein cholesterol fraction. The overall pooled relative risk, RR, for fatal and non-fatal strokes associated with diabetes mellitus was 2.28, with a 95% confidence interval, 1.93 to 2.69, in women and 1.83, that is 1.60 to 2.08, in men. Adjustment for other cardiovascular risk factors had little effect on the RR for stroke, which remained higher in diabetic people, but higher in diabetic women than in diabetic men. The RR for fatal stroke was 2.29, that is 1.73 to 3.04, in women and 1.74, that is 1.45 to 2.08, in men. Sensitivity analyses showed that the increased stroke risk did not vary by region, age, duration of follow-up study, smoking status, year of study baseline, stroke subtype, method of diabetes ascertainment, or data source. Possible reasons for the gender differences are beyond the scope of this chapter and discussed in reference. The point is that diabetes imposes a large excess risk for stroke. And now we will look at the pathophysiology of stroke in diabetes mellitus. The heightened risk of stroke in people with diabetes mellitus is not surprising, given the major risk factors for stroke are largely present in patients with diabetes mellitus. These include hyperglycemia, hypertension, dyslipidemia, obesity, and atrial fibrillation. Individuals with diabetes mellitus also exhibit a hypercoagulable state evidenced by increased levels of clotting factors and fibrinogen and increased levels of plasminogen activator inhibitor 1 and hyperreactive platelets, with enhanced adhesion and aggregation. Diabetes mellitus is a state with increased inflammatory markers as well. And now we will discuss diabetes mellitus and stroke outcomes. Individuals with diabetes not only are at higher risk for stroke, but also have poorer outcomes after a stroke. This is illustrated in a report from the South London Stroke Register on 3,730 patients who had stroke, with events occurring between January 1995 and December 2011. Among them, 3177, that is 85.2%, had ischemic strokes and 553, that is 14.8%, had intracerebral hemorrhage. Outcome was measured by the Barthel index as either a good outcome, Barthel index equal to or greater than 15, or a poor outcome, death or dependency, Barthel index 0 to 14. After 1, 5, and 10 years of an ischemic stroke event, diabetes mellitus was associated with poor outcome, with statistically significant odds ratios varying from about 1.5 to 1.7. There was no association of diabetes with intracerebral hemorrhage. In the short-term setting, observational studies in humans have demonstrated that acute ischemic stroke with concomitant hyperglycemia increases stroke severity and functional impairment compared to those with normoglycemia. Individuals with hyperglycemia had a twofold higher mortality at 90 days than those with normal glucose levels. In acute stroke, the initial ischemia is rarely complete due to collateral blood supply. The ischemic area of hypoperfused, but still viable, tissue surrounding the ischemic region may respond to tight glycemic control with a reduction ultimate brain injury. Neuroimaging has demonstrated that acute hyperglycemia can increase final infarction size, and hyperglycemia is associated with reduced benefit from recanalization with thrombolytic therapy. We will now discuss the management. Let's begin with acute management. Data indicate that diabetes in general and hyperglycemia in particular are potential risk factors for stroke and, by inference, that meticulous blood glucose control should be beneficial in the clinical setting of acute stroke. Despite these findings, a comprehensive Cochrane review, 9, found that the intravenous administration of insulin targeting serum glucose levels within a specific range of 72 to 135 mg per deciliter in the first 24 hours of symptom onset of an acute ischemic stroke did not provide benefit when compared with less intensive glycemic control in terms of functional outcome, death, or improvement in final neurological deficit. It is of note that the number of hypoglycemic episodes was significant. In fact, individuals with glucose levels maintained within a tighter range by intravenous insulin administration experienced a greater risk of symptomatic and asymptomatic hypoglycemia than those in the control group. As there is abundant data to support that hypoglycemia is detrimental to the cardiovascular system, it is prudent to avert it as much as possible. Hypoglycemia is associated with tachycardia, an increase in systolic blood pressure and decrease in diastolic blood pressure, and an increase in cardiac output and myocardial contractility. Moreover, hypoglycemia is reported to cause electrocardiographic changes of T-wave flattening or inversion and ST segment depression consistent with ischemia and QT prolongation that can be associated with arrhythmias. Additionally, hypoglycemia has been noted to result in increased number of RBCs leading to increased blood viscosity, enhanced platelet aggregation, increased levels of platelet factor 4, thromboglobulin, coagulation factor 8, and von Willebrand factor, and increased thrombin generation, all creating a hypercoagulable milieu and increasing stroke risk. To avert hypoglycemia without compromising glycemic control, our institution has adopted protocols that are specific for patients with neurological compromise. While the hospital glycemic goal is 120 to 160 mg per deciliter, we have modified our hospital glycemic target for patients with head injury, status post-craniotomy, stroke, or aneurysm to 120 to 180 mg per deciliter. In intensive care units, intravenous insulin infusions are managed with the assistance of a computer-generated program. This has decreased the incidence of hypoglycemia and reduced glucose excursions. Subcutaneous insulin protocols are used outside intensive care units. In general, a body weight-based insulin calculation is used. The recommended total daily dose of insulin is 0.6 unit per kilogram for type 2 diabetic patients, where 50% of the dose was given as basal insulin glargine and the remaining 50% as mealtime rapid-acting insulin divided equally among each meal. For individuals with type 1 diabetes mellitus, the calculation is 0.4 unit per kilogram total insulin dose with half basal dose and half bolus. A finger stick glucose test is performed before breakfast, lunch, and dinner, and correction rapid-acting insulin is added to the mealtime dose if indicated. The correction insulin dose is based on the individual's total daily insulin dose. Next we will progress to chronic management. At the turn of the 21st century, there was data showing that good glycemic control prevented or delayed the microvascular complications of diabetes mellitus, such as retinopathy, nephropathy, and neuropathy. Although epidemiologic data showed that good blood glucose control was associated with better macrovascular outcomes, including stroke, there was need for prospective studies examining the impact of long-term glycemic management on macrovascular outcomes. Now a somewhat clearer picture has emerged with the publications of the Diabetes Control and Complications Trial, abbreviated as DCCT, the United Kingdom Prospective Diabetes Study, abbreviated as UKPDS, the Veterans Affairs Diabetes Trial, abbreviated as VADT, the Action to Control Cardiovascular Risk in Diabetes, abbreviated as ACCORD, and the Action in Diabetes and Vascular Disease, Proturax, and Diamacron Modified Release Controlled Evaluation. In the DCCT, a randomized controlled trial of intensive versus standard glycemic control in people with type 1 diabetes mellitus, there was a beneficial microvascular, but not macrovascular, effect during the interventional phase of the trial. The average glycated hemoglobin concentration in the standard group was 9% compared with 7% in the intensively treated participants. In a follow-up study, namely, the Diabetes Control and Complications Trial, Epidemiology of Diabetes Interventions and Complications, abbreviated as DCCT, EDIC, a beneficial macrovascular effect emerged at 17 years of follow-up. There was a marked decrease in the occurrence of cardiovascular events in those who had been assigned to intensive glycemic treatment compared with those who had been assigned to standard glycemic therapy, even though the difference in glycated hemoglobin concentration between the study groups was no longer evident. Pertinent to this discussion, the risk of the first occurrence of non-fatal myocardial infarction, stroke, or death from cardiovascular disease was reduced to 57% with intensive treatment, as compared with conventional treatment, with a 95% confidence interval, 12 to 79, with a p-value equal to 0.02. The UKPDS was a study on with newly diagnosed type 2 diabetes mellitus. In secondary randomization, metformin treatment in a subgroup of overweight individuals reduced the risk for stroke when compared with those randomized to chlorpropamide, glibenclamide, or insulin, with a p-value equal to 0.032. The VADT, in contrast to the UKPDS, enrolled individuals with long-term diabetes duration was 11.5 years at entry, type 2 diabetes mellitus. These patients entered with a substantial cardiovascular burden. During the interventional phase of the trial, intensive glycemic control did not result in macrovascular benefit. The average glycated hemoglobin concentration in the standard group was 8.4% compared to 6.9% in the intensively treated participants. However, Similar to the DCCT, EDIC, in a follow-up study, a beneficial macrovascular effect emerged at 10 years of follow-up. There was a decrease in the occurrence of cardiovascular events in those who had been assigned to intensive glycemic treatment compared with those who had been assigned to standard glycemic therapy, even though the difference in glycated hemoglobin concentration between the study groups was no longer evident. There was a significant 17% reduced risk for overall cardiovascular events. This was driven largely by a decrease in the occurrence of non-fatal myocardial infarctions. There appeared to be no stroke benefit, but the number was small. There is some emerging evidence that chronic maintenance of good blood glucose control may have beneficial effects on stroke reduction in both type 1 and type 2 diabetes mellitus, although, admittedly, it is not entirely as consistent and robust as expected. However, data from the ACCORD warrant caution on the aggressiveness of the targeted level of glucose control. The ACCORD was a study on people with long-term type 2 diabetes mellitus. The average hemoglobin concentration in the standard group was 7.5% compared to 6.4% in the intensively treated participants. So the people in the intensive glycemic therapy group in ACCORD achieved substantially lower hemoglobin concentrations than the group in the VADT, that is 6.9%. The ACCORD had to be stopped earlier than planned because those in the intensive group experienced increased all-cause mortality, hazard ratio, HR, 1.22, that is 1.01 to 1.46, with a p-value equal to 0.04, and increased cardiovascular mortality, HR 1.35, that is 1.04 to 1.76, with a p-value equal to 0.02, when compared with those in the standard group. Thus, there does not seem to be any prospective trial data to support the occurrence of hemoglobin concentration less than approximately 7%. Indeed, some circumstances may dictate less aggressive targets. These include those at high risk for hypoglycemia with longer disease duration, important comorbidities, and insufficient resources and support systems. There is no data to support one form of treatment over another. Management must be on an individualized basis with education, healthy diet, whatever exercise the patient can undertake, smoking cessation, and combinations of the vast array of oral and parenteral medications that are now available. Thank you.